Time now for this week's Health Matters. Paul Critz with you, along with P.A. Lynn Szabo. And we're joined in the Fug House today, another guest. It's another guest show. I love having these. Dr. Kevin Caldwell. How are you doing this morning, Doctor?
Hey, Paul. And doing great. Doing great.
I was listening. You guys have been talking for 20 minutes while I've been getting ready here and listening to how much some of the experiences that you've shared together. It occurred to me, if I'm doing the math right, we've got something in the neighborhood of 8 decades of expertise and experience in healthcare here in the room today.
Between the two of us.
Cumulatively. That's amazing. So I guess the reason that we invited Dr. Caldwell on today was to I'm going to sit back and just let you guys, I want to hear from you and your perspectives how healthcare has changed, what has happened, what you came into, the field you came into decades ago, and what it's becoming. And I guess I have this feeling of there being sort of a sense of alarm in that regard. And I'm wondering just what your insights are as folks with skin in the game for a long time.
Can I just say thank you to Dr. Caldwell, because he's telling me he's been in medicine 50 years, and that with his colleague Donna Sund, also a physician, similar amount of time, most of it here, I imagine. You said that you came to the community in 1984.
Yes.
Is that? And there are so many of us that are kind of holding it together and have been here for so long. I think we really have to say thank you for your practice, for Dr. Sund's practice, and for Shelley's practice, because it was pivotal to the community. But I also enjoyed hearing a little bit about what your experiences at the old Seaside Hospital were. Kind of exciting. You said it was the golden age of medicine for Del Norte. What did you mean by that? It sounds lovely.
Well, so I came here from Southern California with my wife, Donna Sund, and we met in family practice residency. And so it just dawned on me recently. So it's been 50 years since I started medical school, which I just find phenomenal. And we're going on 41 years here in Crescent City.
Oh, okay.
What brought you guys initially to Crescent City? Why pick here? So
we did all our training in Southern California, and we were not enamored with Southern Cal. And we were finished. Stayed a couple of years. I had 2 years of National Health Service Corps that I did in inner city Los Angeles.
Wow.
And Donna stayed on at the residency as faculty. And so once I finished my obligation, it was like, hey, we're free. We can do whatever we want. And we started looking in Northern Cal and Oregon. And one day, so Donna said, look, somebody's looking for a partner up in Crescent City. And I was, where's Crescent City? And she said, oh, it's up there above Eureka. And literally I answered, isn't that Canada?
Yeah.
Where is it?
Where again? Yeah.
And so we drove up here, met the folks. It turned out to be at Del Norte Medical Clinic, a well-established clinic here in Crescent City at the time. And one day, we drove in and just absolutely enamored with the place. The beautiful, beautiful environment here. And then that paired with the people, we met all the crew at Del Norte Medical, and they were just wonderful. They just welcomed us with open arms. There was no politics were beginning to form in the city, but no politics here. It's like, okay, you're trained, you just here, there's your office, go to work and do whatever you can do it here.
Wow.
Awesome.
And so we basically just went home and packed and moved here and never looked back.
Oh, yeah.
And so I think long-term, we look at it the other way of just, we are so grateful to this community that we have had such a wonderful life here. We weren't missionaries. We were, from day one, we were Del Norters.
Right on. I heard you had a thriving OB practice too.
Yeah, so we
I
both,
hadn't known that.
Donna and I both did a lot of obstetrics when, for quite a few years, 20, 30 years. And so many families, and it made it, we were part of the community that, because we were having our own babies. And so we were having babies, we were delivering other babies, raising the kids. We were all involved in the community together. It was one big happy community. And
what was the healthcare scene like then? And before we move on, just really quickly, the 2 years that you had to do, and you're working in the inner city in Los Angeles, was this a program that was helping you pay for medical school?
yes,
Yeah.
so
Wow.
they paid for 2 years of medical school in exchange for 2 years of work.
Do they still do anything like that? Is that still?
Yeah, they do.
Do they? Is that
I've
still a
done
thing?
that too.
Wow. Okay.
Yeah,
Okay.
it's
Yeah,
That just seems to make so much sense.
it was a good arrangement.
Right. And a whole other
Yeah.
conversation as to what your takeaways from 2 years doing that must have been too.
Yeah.
Yeah. Okay.
But-
So I didn't
but
want to
it was-
derail. I just
it
wanted
was
to know more.
interesting.
Yeah.
But now I picture, when it's still very clear in my mind, my very, very first day of medical school. And the first thing that the head of the university gave us all a lecture. And all the lecture was about the doctor-patient relationship. And that if you're going to do this, you have to commit right now, you have to be the most honest, integrity, decency, wisdom, compassion, and more than anything, knowledge.
This is first day they're
Right.
dropping all this
I
on
mean,
you?
Oh yeah, they do.
very, and it's
Driving home, just the
and-
gravitas of what you're
and
undertaking.
it's like, if you're not willing, get
Yeah.
out now.
Yeah.
Don't do it. And
Yeah.
if we see you ever break any of that, we're kicking you
Right.
out.
Wow.
It was, the doctor-patient relationship was everything.
Yeah, and they used to say to me, "Disease doesn't take a day off, and neither do you."
Yeah.
You remember that?
Yeah.
Yeah. Oh yeah.
And now we fast forward 50 years later, it's the business of healthcare.
Right.
And it's emblemized by, when we get a letter now from the corporate boss, they start the letter off, this is meant for providers who are caring for Sutter Health patients.
Okay.
And what a sea change that is.
Yeah.
Completely.
That we know now in retrospect, didn't really realize it was happening at the time, that these corporations literally had a corporate plan to destroy the doctor-patient relationship,
Right.
so that they could make more money.
So are they? This is a whole dynamic I haven't heard. Of course, not being familiar. But so it's that these corporations come along, and I want to talk about where they came from, managed healthcare and things that started. But so they basically have turned. They are claiming sort of ownership over the patient.
Yeah.
And that you are working with their patients?
Yes.
So they put themselves in between doctor-patient in that relationship.
Right, electronic medical records facilitated that. There was a paradigmic shift, I think, and I'd be interested in what Dr. Caldwell has to say. But I felt really clearly that my role as a provider became less important than administrative and IT
Right. We've
roles.
talked about this a
Yeah,
lot, actually, on the
right.
show. Yeah. Yeah.
And fair to say? Is that?
And and so back then, even back there in the 80s, before we moved, the beginnings of that were happening. There was a CEO from one of the first HMO organizations who famously said, "Those damn doctors are standing between me and my money."
Like out loud, where
Out loud.
people could hear this?
Out loud. And there were intercepted corporate plans for how they're systematically going to dismantle the doctor-patient relationship.
Are we talking like Kaiser and corporations like
No,
that?
So Kaiser's kind of an exception.
How's Kaiser an
in
exception?
a good way?
I've always had a good feel. I've been a Kaiser
Yeah.
patient, and I've always felt really good about that
They
and
are.
proud. But I didn't know if I was wrong.
And see, they did it right. Kaiser is the administration side. Permanente is the physician side.
Okay.
So Permanente, the physicians were in charge of patient care and patient protection.
Okay. And those two aspects were kept separate
They
then
were
within
kept
the
separate.
Kaiser model, but not so elsewhere in the industry?
Right.
Okay.
And so we'll get to when we got to Seaside, how great it was there. But before leaving Southern Cal, we were still in touch with all of our fellow residents who everyone's dispersing and trying to get their first jobs.
Right.
And I remember some of my buddies saying, "What? I'm gonna go open up an office in Palm Springs and it's really good. I signed a contract with this insurance company and they have a whole panel of patients for me. And I'm going to take care of those patients and they tell me how much money I'm going to get." And I was like, wait a minute. These are insurance company patients? Wait a minute, that's just not what we signed up for here. And that was, 1983, 84. And then we moved away and we came here. And it was like going back in a time machine to the golden era of where doctors were in charge here. And there was a medical staff and a very organized medical staff and took patient care, patient protection very seriously. And that like credentialing doctors was a huge part of it. It was a chore to get accepted onto the medical staff. And they overlooked you. You had all your work. Doctors would come in following you, making sure you were doing a good job. It was taken very sincerely.
Wow.
That you had to do that. And being way up here, it was like we were cut off from the rest of the world. So I didn't know it, but the rest of the world was going healthcare business while we were still living in this golden era. And life at Seaside was really good.
Who ran Seaside?
So it was what is now the healthcare district.
Okay,
it
that's
was a hospital district. So these hospital districts had started after World War II for rural communities to supplement them so that they could have a hospital.
Okay, and funds coming from
Feds.
From feds, okay.
Feds and property tax.
Okay,
mostly.
like a school, like a district, like that sort of district, sort of.
Right.
Okay. I'm just curious because I was trying to think back about how did that used to happen before they were all, nonprofits or private companies running them. I was going, who ran those? How did the hospitals used to, when I kind of grew up with the vague memory of a hospital being almost like a public utility.
Yeah.
And it wasn't something that was a business, that people
Right.
worked for. It was something that you paid for and it was always there for. And I don't know where that
It was like a
that vestigial-
community goal.
Yeah.
So I know nurses that retired from there that have incredibly great memories about it, and people who got care there in their younger years who felt like really cared, and they knew the doctor that came to see them, once or twice a day. And it was still when family practice physicians were rounding. That was kind of a loss
Yeah.
when that changed.
Yeah.
So we would see all the patients. That would be living in the hospital. We were constantly in there. We didn't have to even ask for consults because we knew we'd run into our fellow physicians. And so if I needed a surgeon, an ortho, I just stop them on rounds in the morning.
Wow.
And
Right.
people,
The curbside.
just curbside, where to go from here. Everyone doctors are notoriously kind of independent and grouchy, but when it came to, hey, I need help with my patient, boom, they'd be right there every time. And then the whole staff, it was, the old hospital was much more open, where as you walk through the hallways, you could see in the administration offices, and it was just sort of a happy, friendly place, everyone working together. And that's when Sutter came just a few years later, but the bookkeeping was getting very complicated because of Medi-Cal and Medicare and this little country administrator. It was over his head. So they were hired as consultants to manage that bookkeeping side of it.
Wow. Okay. Okay.
Oh, I didn't know that.
What complicated? Okay. So yeah, what complicated the bookkeeping then? What necessitated bringing in
I
these
think
third parties?
lots and lots of new rules
Okay.
that you had to follow all these rules to get paid by Medi-Cal or Medicare. Just lots and lots of rules. So it was getting too complicated.
Sure.
So they
At a certain point, it's cost effective to pay somebody just to stay on top of all of that.
So, you're
you don't
paying, and they got paid to be business managers. And again, we were so far away from the rest, 350 miles away from their core properties. They just left us alone.
Yeah,
So
yeah.
we lived the old days way up to like probably, in retrospect, I know like 2009.
How much longer did we get being so remote up here?
I think when 2009 they were ordered to bring us in alignment with the rest of the corporation.
Okay.
And boy, that's what started the fight. And it was a fight. It wasn't because the first thing I found out they put a patient care policy into effect that had not gone through the medical staff and was not approved by the medical staff, which is just a huge no. I mean, that's not like shades of gray. That's
Right.
Few things in life are black and white, but that was black. You can't. And it just so happened, beginning 2010, I became chief of staff for all sorts of good reasons. But it was like this was the first thing I found out is here sign this. It hadn't been signed yet.
Oh wow.
And I'm like, well, wait a minute. This policy's been instituted, and
Do you recall anything about the specifics of the policy?
yeah, it gets sort of tangential, but it had to do with obstetrics
Okay.
and having to do sponge counts at a normal vaginal delivery, which I think most people wouldn't get that, but it would cause an enormous waste of time and distraction away from the mother and baby.
Okay, right.
For not, I mean, sponge counts are very important when you're doing general surgery
Like
and
invasive,
open somebody's belly.
Right.
Right.
But with a normal delivery, you're not closing in any cavities. And the very normal part in your training was after you think you're done, the last thing you do is go look again. Is everything? Did the bleeding stop? Is everything out?
Right.
So the physicians were internalizing that practice in a really common sense way and didn't need to be told that.
Right.
Well,
But
and what was the reasoning from the corporate reasoning behind it? Just a CYA sort of thing?
apparently, because the rest of Sutter Health did that.
Oh, so it was just a pointless. This is okay.
Yeah.
Okay.
Yeah.
All right.
And
But
and
definitely
it's-
not a medical decision being
Right.
made, right? Yeah.
And it was dangerous in that when you do sponge counts, it's very time consuming because when you bring out a new pack, at least two of you have to sit there and count and make sure that there really are just 10 in there. Like maybe it was mispacked and that there were really 9.
Yeah, and that'll
or-
throw your whole day off. Yeah.
So, and sometimes these deliveries get really exciting and things are moving fast. And if you're distracted by trying to count sponges, it's not good.
Right. So how did you deal with that? I mean, if this was the sort of like first indication of that sea change? Did you recognize it at the time as being, this is significant? Or you said it was like black and white. Yeah.
Right then, and I was like, no problem. I go to the hospital board, the board of trustees who oversee the hospital and our governing board. So, I mean, they've really got the power. And they're all buddies. I know them all. And it's like, hey, yeah, you guys, you can't do this. And here's why. And the whole table is looking at me with daggers, like, go away. The CEO said this is what we're going to do. And so from then it just got more and more complicated. And ultimately, I feel like the community lost. We got crushed.
Can you take us through that ultimate or that subsequent sort of movement? Then how, it starts kind of simple enough. It seems like let's just all get on the same page here organizationally with counting these sponges at an inopportune time in a medical estimation. But then what are subsequent steps after that lead? Here we are at the end of that progression, being crushed. So what else happens then in that?
Or is it okay if we go back to how great Seaside
Oh,
was?
Sure. Sorry.
It was the heyday. So we all knew each other. The doctors were in charge of care. A great example, when we got here in '84, the delivery room for obstetrics was truly like a medieval torture chamber. It looked horrible. And the labor room was all cement walls with no
Wow.
windows, institution green, with 2 beds close together, so you should have 2 laboring patients at the same time. And then when it was time to deliver, you move them to another room with no windows, and the big delivery bed really looked medieval.
Oh my God.
And so Donna and I were planning on having a baby. And she was,
Oh my gosh.
But not here.
but this was what was such a big positive thing here. It's like you see something that needs fixing, and you can fix it. And so within 10 months, mainly because of Donna, there were 4 beautiful delivery rooms, where they called labor, delivery, postpartum. Everything went in one room, 4 of them all facing out onto the ocean.
Nice, because you got that view there. It was such a wonderful. Yeah.
And they were on the ground floor, so it was just like you looked right out to the ocean. It would be common for a sea lion to be up on the rock, kind of looking in. It was
beautiful.
spectacular.
Right,
But I mean, just a great example of if something needed fixing, you could fix it, and everyone was in on it. And if Donna wanted to take the lead, good, and it was done.
Right.
And so there were a lot of things. In fact, a couple of the doctors they bought the first CAT scan at Seaside.
Wow, just privately themselves?
Yeah.
Wow.
First mammogram machine they bought when we were first coming. And so so this was all the heyday. And Sutter tried to make a few inroads to do what we now know was they were doing in the rest of the state, but they send up some of their MBAs dressed in suits and want to meet with the medical staff, because what a great offer. We'll just buy your practice, which is what they were doing all over Northern California, buying up doctor practices, because you don't want to do all that boring stuff. We'll do the business side.
And so you get just a salary for this sort of thing, a commission? How does that work for the doctor?
It was unclear, and you can just do medicine, and none of us had any trust. So I mean, it was like they were just laughed out. No, we're not doing that. And so we again continued on till like 2010. Wow. And it was just great. So even when they switched to the new hospital, it still ran like that.
Wow.
And now they just kept encroaching more and more. Like Lynn was saying, the electronic health records was really weaponized. And then they started with coding. They made coding, meaning you did this thing, there's a code that goes with you doing that thing, and there's a price tag that goes with that code.
Right.
So they've started making it more and more complicated, and that the coding was defined by the electronic health record. So you had to have all these things on the electronic health record in order to code things. And then the coder went off to a mystery box There was
Right.
some room, some guy named a coder who had a special book, and he looked through this electronic health record and coded it. And inevitably, every encounter was a really high level
Right.
of coding. And then, but what there wasn't any coding for was disposition. So what happened?
Right.
What was the, and so, there-
Well, let me understand that. So no coding for the outcome, the totality, the outcome of a visit of some sort of something. You've got all the bits and pieces.
Or the essence of a visit.
Right, right.
Because you can, you go in there and somebody has a catastrophic thing going on, and maybe they have anxiety related to it in their life, and you put them on, a medication and refer them to counseling. That's medically pretty uncomplicated. But the presence of the human therapeutic touch there's no way you can code for that.
Right.
So it becomes less and less and less important. And so providers are in, and then we have pressure to see more people.
And just
So-
to hit the price points, right? I
yes.
mean,
Yeah. Don't make it more complicated
Right.
than it has to be.
my
But really, humans are complicated, and the practice of medicine is complicated.
Yeah, necessarily.
And you can't stuff that into an electronic note. You really can't. So it becomes more automated and less flexible.
When did that happen?
so starting around 2010,
Okay, just
and
about
it's
that same sort of
progressively getting worse. And so now it's common we get a visit, an emergency room visit for one of our patients, and it's many pages long, many pages, most of which don't say anything. And it's very common for the chief complaint, which is how you always start off your encounter, the chief complaint, for the chief complaint to be abdominal pain. And then the final diagnosis, abdominal pain. And disposition, discharge home. And,
Wow.
There's
and-
no medical thought in that.
Yeah.
Not really.
No.
Not really.
And if there is, there might be a paragraph of which is generated by a macro key or an AI for the differential diagnosis for abdominal pain. So there can be a whole long just AI generated
couple of
paragraph.
pages.
So see, we considered everything.
Oh my God.
Yeah.
Right. And then the patient brings you what they get as a patient after visit summary, and they want you to make medical sense of it. And, they said, for example, if you go in with a sore throat, the doctor said I had pharyngitis. Okay, that's sore throat.
Yeah,
That's not meaningful.
So we have exactly 2 minutes left.
Oh, thank God.
What can you do with your experience and all the years that you both have spent in the exam room and the time you have to spend now in front of it? What can you possibly do to counteract that? Is it a losing battle? What hope is there?
I'd say fighting off despair is a common
Right.
emotion. I've been getting a little help lately where if I can call out an individual case with an individual doctor, I'm finding the doctors are still responsive. They, it's more like they get it like, maybe we've drifted down the wrong path here. But so far I'm finding they'll respond.
Okay, good.
So there's,
There's still somebody at the other end of the line then?
Yeah. It doesn't fix the system, but case by case, I can say, okay, we can make a difference.
Wow. Okay.
I think there's 1,000 little points in the day where you can have a quiet resistance, and I think that's one of them.
I don't know. We've just about out of time. I'd love to have this conversation, or at least continue this conversation again at some point, because it's really,
It
really.
needs a part two.
I think so.
Yeah.
I think so. So, Doctor, thanks for coming in, and hopefully we can get you back sometime to
I
continue the
loved
story.
it. Loved it.
Loved it. Good. Lynn, any idea about next week?
Well, I'm a little worried about some of the information about safety for a community in relation to like what avian flu is doing, and is that lettuce really safe to eat? And so I was thinking of giving some areas where you could go and seek out the information that's kind of been press pause. It's not available
Right.
in the same governmental way that we should have it.
Okay. All right. Look forward to that, Lynn. Thank you.